Hello everyone, welcome to this video on Appendageal Disorders Part 1. In this video, we will be talking about the structure and physiology of the hair follicle as well as some important hair disorders. So starting with the origin, the hair is an ectodermal appendage. So the origin is from the ectoderm. Now, talking about the structure, in the hair you see this small little muscle coming from the skin and inserting into the hair follicle at the level of the dermoepidermal junction. This muscle is called as the erector pili muscle. The insertion of this muscle divides the hair into two parts. Above the insertion of the muscle, we have the upper segment, and below the insertion of the muscle, we have the lower segment. Now, there is this small little yellow colored structure that you see which is opening into the hair follicle. This is the sebaceous gland. So, the sebaceous gland opens into the hair follicle. Now, the sebaceous gland also divides the upper segment into two further parts. From the opening on the skin to the insertion of the sebaceous gland, this part is called as the infundibulum. And from the insertion of the sebaceous gland till the insertion of the erector pili muscle, this area is called as the isthmus. So the upper segment is further divided into infundibulum and isthmus by the insertion of the sebaceous gland. Coming to the lower segment, here we have this inverted V-shaped zone. This is called as the Adamson's fringe. This part has an importance in terms of having the keratinized part of the hair follicle above it, and below the Adamson's fringe we have the non-keratinized part of the hair follicle. Apart from this, it also divides the lower segment into two parts. From the insertion of the muscle till the Adamson's fringe, we have the suprabulbar area of the hair, also called as the stem. And below it, you see this rounded structure. This is called as the hair bulb. Okay, so upper segment, lower segment, infundibulum, isthmus, suprabulbar and the bulbar part of the hair. All clear? In this bulb, what you see are these rapidly dividing cells, which is called as the hair matrix. And you see this invagination of the dermis into the hair bulb. This is called as the dermal papillae. The blood supply and the nerves, they all are there in the dermal papillae. In some parts like the axilla, nipple areola and the groin, there is another gland which is opening into the hair follicle above the insertion of the sebaceous gland. That is called as the apocrine gland. So the insertion or the opening of the apocrine gland duct is above the sebaceous gland. I hope the structure of the hair is clear to you. Now, in this, a very important thing that you have to understand is where are the stem cells of the hair located. The stem cells are located in this bulge area. You see this small bulge here? Yes, this is called as the bulge area. Where is it located? It is located above the insertion of the erector pili in this area, that is the isthmus. So important to remember that the bulge area is present within the isthmus part of the hair. And in this bulge, we have the stem cells. Now, these stem cells are multipotent cells. These multipotent cells travel from the bulge area into the hair matrix where they divide and form the hair. Now, if there is a damage to the bulge area, the stem cells will be damaged and this will lead to a permanent and an irreversible alopecia. So if the stem cells are damaged, how will the hair be regenerated? It cannot be. So there will be a permanent, irreversible alopecia when there is a damage to the bulge area. Now coming to the cross section of the hair. So when you see the cross section, here is the hair. So this is the hair. Outer to the hair is the inner root sheath, and then we have the outer root sheath, which is enveloped by this glassy membrane, also called as the hyaline membrane, and surrounded by the dermal or the connective tissue sheath. So this is how you see the hair when you see in the cross section. The hair enveloped by the inner root sheath, the outer root sheath, the glassy membrane, and the dermal sheath. Now coming to the hair, this yellow colored structure here which you see. So in this hair we have further 3 layers. There is the medulla, which is in the center, surrounded by the cortex, and the third layer of the hair is the cuticle. So in the hair we have the medulla, cortex, and the cuticle. Now talking about this pink colored membrane here, which is the inner root sheath. The inner root sheath also has 3 layers, and these layers are important to remember. So from innermost there is the cuticle. Yes, I just told you that a cuticle is part of the hair shaft, but we also have a cuticle layer in the inner root sheath. Then there is the Huxley layer and the Henle layer. So 3 layers of the inner root sheath, the cuticle, the Huxley layer, and the Henle layer. In fact, the cuticle of the inner root sheath is entangled with the cuticle of the hair shaft, and together it binds the hair shaft to the layers. So now coming to the types of hair. Here we have 3 important types: the lanigo hair, vellus hair, and the terminal hair. These lanigo hair are intrauterine hair, while the vellus and the terminal are the extrauterine hair. Interesting? Yes. So coming to the lanigo hair, as I told you, these are intrauterine, so they are present in the fetus. These are very soft, fine hair, and they are unmodulated and non-pigmented. So these are soft, fine, unmodulated, non-pigmented hair which are present in the fetus, and they generally shed around 7th to 8th month of the intrauterine life. But if a baby is born premature, so if a baby is born premature, that baby is going to have lanigo hair, which will eventually shed off in a month or 2. So the importance is that these hair may be present in a premature baby. Now, coming to the other 2 types, which are the vellus and the terminal, it is important to know the differences. The vellus hairs, as you can see in the image, are short hair. Generally, they are less than 2 mm in length. They are fine, very thin, non-modulated, and non-pigmented. Also, if you see the location of the bulb here, they are quite superficial. The bulb is present in the reticular dermis. The bulb is present in the reticular dermis. On the other hand, you see these terminal hair in this picture. They are capable of growing very long. Then they are thick, dark hair which have a medulla, and they are pigmented. So everything is opposite here. They are long, thick, dark, medulated and pigmented hair. Also, if you see the bulb, this is much deeper here. So the location of the bulb is in the subcutaneous layer. So these hair are anchored deeper in the skin. Their bulb is in the subcutaneous layer. So the differences of the vellus and the terminal hair should be known. If you look at your face on your forehead, you feel very fine fuzzy hair here. These are the vellus hair. While on the scalp, on the body, these pigmented black hair, these are the terminal hair. What happens if a patient is suffering from hirsutism? In the hirsutism, the vellus hair convert to terminal hair in the androgen dependent areas. So when a girl suffers from hirsutism, the peach fuzz on the face here, the vellus hair convert into terminal hair. But this happens only in the androgen dependent area. This is the importance of knowing these two types. So next we come to the hair cycle. This is a process in which the hair grows, passes through different stages, sheds off, and then a new hair comes. So this goes in the form of a cycle here. Starting from the anagen phase, the hair grows into catagen, then it goes to telogen, ultimately shedding off, which is called as the exogen phase. Now, anagen, A for anabolism. This is a phase where a lot of rapid mitosis and growth is happening. Therefore, this we call as the phase of growth and activity. In this phase, the hair grows longer and longer. About 80 to 85% of the hair are present in anagen phase at one time. And it grows for about a period of 3 years. So the duration of the anagen phase is about 3 years. From the anagen, the hair goes into the catagen phase. C for catabolism. So this is the phase where everything is broken down. There is a lot of apoptosis happening, which leads to involution of the hair. So this is the phase of involution. Around 1% of the hair are present in catagen phase at one time, the duration being around 3 weeks. Once the breakdown has happened, now the hair goes into the telogen phase where it is dormant or the resting phase. Nothing new is happening, nothing is breaking down, the hair is just resting. So this is the resting phase. This will be about 10 to 15% of the hair in the scalp at one time, and the duration of this phase is about 3 months. Once the telogen phase ends, the hair will shed off. That is called as the exogen phase. So just a quick revision here. Anagen is the phase of growth and activity. Catagen is the involution or the apoptotic phase, and telogen is the resting phase. Also important to know that in the anagen phase, there are 80 to 85% of the hair and the duration is 3 years. So the maximum percentage of hair and the maximum duration, these both are the anagen. So 80 to 85% lasting as long as 3 years. On the other hand, telogen is just about 10 to 15% of the hair at one time and the duration is 3 months. So what is the normal anagen to telogen ratio in the scalp? That is about 8 to 9:1. Important to remember this ratio of the anagen to telogen hair. The normal ratio is 8:1 or 9:1. Now, coming to the differences of the anagen and the telogen hair, how do you make out looking at the image, which is what? When you see the anagen hair, you see that it is darkly pigmented and the bulb here is bent, giving it a hockey stick appearance. Because the bulb is loaded with the rapidly dividing matrix cells, so this gives the hockey stick appearance. Another finding that you see here is that you see the root sheet here. So this is visible when you pluck an anagen hair or when you see it under the microscope, you see the root, sheath, and the hockey stick. On the other hand, the telogen hair is lightly pigmented, and the bulb here is in the shape of a club, which is why it is called as the club hair. So the difference between these two appearances you should be knowing. Now, coming to the growth rate. The growth rate of the hair is about 1 centimeter per month. This we are talking about the scalp hair. Okay, so the rate is about 1 centimeter per month, which is 0.35 millimeter per day. And how many hair shed daily? About 100 hair a day is considered to be a normal shedding. Now, coming to hair disorders. When there is a loss of hair, it is called as alopecia. So alopecia means loss of hair. Now, depending upon the mechanism, we have two types of alopecias. Number one, the non-scarring alopecia, and the second is the scarring alopecia. The scarring alopecia is also called as cicatricial alopecia, and the non-scarring is also called as non-cicatricial alopecia. Okay, now what are the differences between these two? As the word mentions, non-scarring. So this is a temporary hair loss. There is no damage to the stem cells, and there is a potential of regrowth happening here. Okay, so non-scarring is a temporary hair loss. If treated, there will be a regrowth. On the other hand, in scarring alopecia, as the name suggests, there is scarring. So this is a permanent type of hair loss, and there is no regrowth. No hair will come back even on treatment. So these two differences between scarring and non-scarring alopecia should be clear. Now, talking about the different types of non-scarring alopecia, here we can classify them based upon the pattern of the hair loss. If it is a patterned hair loss, or a patchy hair loss, or a diffuse hair loss. So in patterned hair loss, we have androgenic alopecia. So here the hair loss is in a specific pattern. And then we have the patchy, in which there may be patches of hair loss. We have alopecia areata, trichotillomania, Tinea, Capitis, and the moth-eaten alopecia, which you see in secondary syphilis. So these are the important types of patchy alopecias. Now coming to the diffuse alopecias. In diffuse, number one, we have the effluviums, where we have the Anagen and the Telogen effluvium. And then we see diffuse alopecia in patients suffering from SLE or thyroid dysfunction. Okay, so what is the classification? We have patterned hair loss, patchy hair loss, and diffuse hair loss. Important to know these different subtypes, because that is what narrows your options in the exam and also when you are seeing patients in the clinic. So now coming to androgenic alopecia, which is also called as patterned hair loss. So as we just saw, this is a patterned hair loss, means the hair loss begins and progresses in a characteristic distribution in both men and women. What is the pathogenesis? Now, andro means hormones, and the genetic means there is a genetic tendency. So the name of the disease in itself tells you the pathogenesis. There is a hormonal basis coupled with a genetic tendency. Now, what is the important hormone here? You see this in the image. T here stands for testosterone. So the most important hormone here is testosterone, which is converted by an enzyme 5-alpha reductase, which is present in the dermal papillae. And this converts testosterone to 5-dihydrotestosterone, which is many times more potent at causing hair loss. Now, the hair loss also progresses in a pattern, even in that one hair. See what is happening here. This is a thick terminal black hair. Due to effect of this hormone, this becomes smaller and thinner. So this is called as the miniaturization of the hair. So here the hair becomes smaller, thinner and lightly pigmented as the disease progresses, ultimately forming a vellus hair. So a terminal hair is being converted to a vellus hair in this disease. Ultimately it sheds off. Also, this hormone shortens the anagen phase. So the anagen phase is shortened. So more hair will be converting to the telogen phase here. The normal anagen telogen ratio, which is 8:1, here it is about 4:1. So you have less of hair in the anagen and more in the telogen phase in the areas which are affected by this alopecia. So two things that you have to remember: the enzyme, which is 5-alpha reductase, the hormone responsible, which is 5-dihydrotestosterone, and what is happening here? There is a miniaturization of the hair leading to vellus hair, and the anagen telogen ratio is reduced. Clear to everyone the pathogenesis of AGA? Now let us come to the clinical features. In the men, where does it start? So it starts from the frontotemporal area. So the first thing that you see is a frontotemporal recession. This is the temporal and the frontal recession that you see in these patients. Ultimately, the hair loss will progress on the vertex and the top of the head, leading to the typical patterns that you see in AGA. Importantly, remember, where does it start? It starts from the frontotemporal area. And then it progresses. The grading of the progress is assessed by a scale which is called as the Norwood-Hamilton scaling. So the scaling process that we use here is the Norwood-Hamilton scaling. In the women, where does it start? In the women, it starts from the top of the head. So from the top of the head, it starts. How do you assess? You see the width of the central parting. So the central parting becomes wider and wider as the hair loss progresses in this pattern. And this pattern is called as the Christmas tree pattern of the hair loss. So where do you see Christmas tree pattern? You see it in female pattern hair loss or androgenic alopecia in the women. Now, one important point that you have noticed in the image, you see the frontal hairline here? Yes, the frontal hairline is maintained. So very important, the frontal hairline is maintained in female pattern hair loss. Clear? So it starts from the top, progresses to the sides in the Christmas tree pattern. All this while the frontal hairline is maintained. How do you grade the severity? You see, as the disease moves from one to next, the central parting becomes wider and the hair becomes more thinner in this area. So this grading is called as the Ludwig scale. This is called as the Ludwig scale. So it was Norwood-Hamilton scaling in the men and Ludwig scale in the women. Now, how do you treat these patients? There are only two two categories of drugs which are FDA approved. In the topical drugs, we have minoxidil, and in the oral drug, we have 5-alpha reductase inhibitors, which are finasteride and dutasteride. So these are the two types of drugs that we can use in our patients. So coming to the topical management, the drug that we use in topical management is minoxidil. You know from pharmacology that minoxidil is a potassium channel opener. By doing this, it is a arteriodilator. Now, if a drug is going to dilate the blood vessels in that area, number one, it will increase the blood supply. So that is one of the mechanisms by which minoxidil is effective in AGA. Secondly, on its own, it also prolongs the Anagen phase. So these are the two ways by which minoxidil is beneficial in AGA. Now, what is the concentration that we use? We use 5% minoxidil twice daily in the men and 2% minoxidil solution twice daily in the women. Important to know the percentages: 5% in men and 2% in the women. Now, coming to the oral drugs. In the oral drugs, the group that we use are 5-alpha reductase inhibitors. Yes, so these are the drugs that are useful in AGA because this was the enzyme which was converting testosterone to dihydrotestosterone, which was bringing about the miniaturization. So if this enzyme is inhibited, you can slow and maybe even reverse the process of AGA. The two drugs that are approved here are finasteride and dutasteride. Dutasteride is much more specific for the type 2 subtype of this 5-alpha reductase. Okay, so these drugs are not anti-androgens. They just reduce the conversion of testosterone to dihydrotestosterone. And an important side effect of these drugs is premature ejaculation or ejaculatory dysfunction, and seen in very few, maybe just about 2 to 3% of the patients, but this is an important side effect that you have to remember. And another use of this group of drugs is also in the benign prostatic hyperplasia that you see in the. So next we come to effluvium. So what exactly does effluvium mean? It means excessive hair shedding. Now, this shedding is happening all over the scalp, which is why it is a type of the diffuse non-scarring alopecia. And depending upon hair stage that is affected, whether it is the anagen hair that are affected or the telogen hair that are affected, we have two types where we have anagen effluvium and telogen effluvium. So as the name suggests, in anagen effluvium, it is more of the anagen hair that are shedding. In telogen effluvium, it is more of the telogen hair that are shedding. So where does anagen effluvium happen? It generally happens in cancer patients who are undergoing chemotherapy. So this generally happens in cancer chemotherapy patients. Now, when chemotherapy drugs are given, they will act on the rapidly dividing cells, and hair matrix is one of them. So the anagen hair which are undergoing anabolism, they are rapidly dividing. They are the most affected by these chemotherapy drugs. It causes an arrest of the anagen phase and the root becomes dystrophic, ultimately leading to the shedding of the hair. And the patient comes with a history of excessive shedding of hair within 2 weeks of starting chemotherapy. So the gap is generally 2 weeks and there is excessive shedding of hair all over the scalp, over the entire scalp. And the shedding is so extensive that the patient almost loses all the hair on the scalp. See, 85% of the hair are in the anagen phase. So if you lose about 85% of your hair, that is akin to balding. So the patient here complains of balding as if I am going bald. Now, on stopping the chemotherapy, the hair will regrow, which is why this is a non-scarring hair loss, because the effect of the drug will go, the matrix will again, divide again from the hair, and it will be a normal growth after stopping the drugs. So no treatment is needed here. Just stopping of the chemotherapy is going to bring back the hair. This is the Anagen effluvium. Important points to remember: starts at a very short gap of the trigger. So within 2 weeks of the chemotherapy, the hair fall will start. There will be excessive shedding. The patient may go bald. Now, next we come to telogen effluvium. In telogen effluvium, there is a trigger here. This trigger will convert the anagen hair to telogen hair. Okay, so there is a trigger will convert anagen hair prematurely to telogen hair, and telogen hair will rest on the scalp for about 3 months, after which there will be a complaint of excessive hair fall. Okay, so very important here is that there will be a trigger which will cause hair fall, but at a gap of 3 months from the trigger to the shedding. Now, this is a very important history that you will get in the exam. What are the triggers? The triggers here are: number 1, delivery of a baby. So the woman has just given birth to a baby. Secondly, there may be a short, severe illness like dengue, typhoid, COVID, or any other severe systemic illness. Thirdly, the patient may have undergone a surgical procedure or a road traffic accident. So these are different forms of stressors which act on the hair, cause a premature conversion of anagen to telogen phase, which will lay dormant for 3 months and then shed off. The most important point is the gap of 3 months between the trigger and starting of the hair fall. Here also patient will give a history of excessive shedding, but normally telogen is about 10% of the hair. Here, even if they convert to 30%, you have a 30% loss of hair, but then also there will be no balding. So very important to see in this image also, there is a thinning of hair all over the scalp, but there is no balding. That is how you can differentiate a telogen effluvium from an anagen effluvium. And this is a self-limited disease. Once the trigger is gone, the hair cycle will convert to normal. After that, the shedding will stop. Okay, so this is a self-limited type of hair loss. No treatment is required. Now, coming to the patchy types of hair loss, here the most important that we start with is alopecia areata. Alopecia areata is an autoimmune type of a disease mediated by the Th1 cells. So this is an autoimmune type of disease mediated by the Th1 cells. The target here is the black Anagen hair bulbs. Yes, you have to remember that this is a type of disease which affects the black hair. So it affects the black anagen bulb of the hair. And what does it lead to? It leads to this type of a patchy hair loss, which is about round to oval in shape, and there is a complete alopecia in the patch. There is a complete bald patch, and the skin here is smooth with no signs of inflammation. Okay, so what do you see here is a round circular patch of alopecia with complete hair loss in the patch and the skin is smooth, there are no visible signs of inflammation. That means no scaling, no vesicles, no pustules. And I told you that it affects the black hair, so there will be a sparing of the gray hair. In the patch, some non-pigmented or gray hair may be visible. And when alopecia is affecting a lot of area, so the black hair is gone, only gray hair are left, this can lead to a phenomena which is called as going gray overnight phenomena, also called as kinnitis subita, where kinnitis means gray, subita means sudden. So there is a sudden graying of hair over the scalp. This is how you see alopecia areata. And when you examine closely, either with a magnifying lens or you do a trichoscopy, that is dermoscopy of the scalp hair, you see this beautiful sign in alopecia areata, which is called as the exclamation hair sign. This is called as the exclamation hair sign, where as you see, the distal part of the hair is broad, while the proximal part here is thinner. So this is called as the exclamation mark sign. Again, look closely in this picture. This is a very beautiful exclamation mark sign that you see. This is generally seen on the periphery of the lesion, and having more of exclamation mark hair, that is a sign that the disease is active. So this tells you about the activity of the disease. That means the lesion may enlarge, it may spread. So these exclamation mark hair are a sign of activity of the disease. Very important image-based question from alopecia. Now, when the histopath is done, what do you see? Here, this is the hair bulb. Around the hair bulb, you see a lot of lymphocytic infiltrate. So you see a peribulbar lymphocytic infiltrate. A peribulbar lymphocytic infiltrate is what you see in the histopath of alopecia areata. Now, these lymphocytes which are targeting the bulb, they appear like a lot of bees which are circling around a target. So this appearance is also called as swarm of bees appearance. So just a named histopath sign here, which is the swarm of bees appearance that you see in alopecia areata. And one more point I want you to see here. I say that there is a peribulbar lymphocytic infiltrate. So the immune action, the inflammation is around the hair bulb. And where are the stem cells located? They are located above that part. They are located in the isthmus bulge area. So that bulge area is safe. The stem cells are safe. Once the inflammation will subside, again the hair will regenerate. So this is how you can understand the importance of bulge area in the non-scarring alopecias. Now, coming to different patterns of alopecia areata, depending upon what parts of the scalp are affected or how much of the scalp is affected, we can have different patterns. When the margin is affected, like you see here, when the margin is affected, this is called as the euphiasis pattern. Here, the alopecia is affecting at the hairline margin. More often, it is the occipital part, the back, where you see that full band of alopecia areata at the hairline. Then we have alopecia totalis. Totalis here means that entire scalp, total scalp is affected. There is no hair remaining, while eyebrows and mustache hair are intact. So alopecia totalis is affecting all the hair on the scalp. Now there is another type which is called as alopecia universalis. Universalis means entire body hair is involved and they are gone. So alopecia universalis is affecting the body hair on the entire body, including scalp, eyelash, arms, legs, everywhere the hair is gone. So these are the three patterns that you should remember: oophiasis, totalis, and universalis. Now, sometimes the patient may also tell you that they have a patch of alopecia on the eyebrow or the beard. Now, if the characteristics are same, the skin is smooth, bald, there are no signs of inflammation, you know you are dealing with alopecia areata. So yes, alopecia areata can affect other body areas as well. Now, in a lot of patients with alopecia areata, there are also nail changes. So what is the most important nail change that you see? You see pitting. So most important nail change that you see in alopecia areata is pitting, which crateriform depressions on the nail plate. So when you see from the side, there are small depressions on the nail plate. This is called as pitting. Now in alopecia areata, the pitting is superficial, fine, and regular. So when you see this nail, you see that the pits are superficial, then they are fine, and they are arranged regularly. A way to remember this is this mnemonic SFR. So superficial, fine, regular pitting you see in alopecia areata. Because of this regular pitting, it is also called as geometric pitting, a geometric nail, and also called as sandpaper nail. Because nail surface becomes so rough because of this pitting, it is also called as sandpaper nail. So next finding that we see here is called as tracheonychia. Tracheonychia means roughening of the nail surface. Alopecia areata is the most common acquired cause of tracheonychia. Most common acquired cause of tracheonychia. Then we have some prognostic markers in alopecia areata. What will be the tendency for the disease to show regrowth? When will it show regrowth? How much will it progress? So all of these can be defined by certain factors. Early onset of the disease is a poor prognostic marker. Then the different patterns that we have seen: oophiasis, alopecia totalis, alopecia universalis, all of these are again poor prognostic markers. Presence of nail changes and certain associations with other autoimmune diseases, especially the Th1 type like vitiligo, Hashimoto's. All of these, when present, can tell you that there is a poor prognosis, and also association with atopy. That is, the patient has tendency to allergies. So all of these are poor prognostic markers in alopecia areata. When you treat the patient, you tell the patient that in 50% of the cases, the disease will self-resolve with a spontaneous regrowth. So in about 50% of the patients, there may be a spontaneous regrowth. But if you're asked the treatment of choice is intralesional steroid injection. So treatment of choice is intralesional steroid injection. As you can see in the image, within this patch of alopecia areata, the steroid is being injected. So this is an intralesional steroid injection. The drug that we use here is triamcinolone acetonide. So if you have an option, intralesional triamcinolone injection, that is also correct. Now, for patients who have more widespread disease or which is rapidly increasing in size and number, you give systemic treatments. In systemic treatments, we can use steroids, azathioprine, cyclosporin. All of these are other options for treatment. But what is the treatment of choice? Treatment of choice is intralesional steroid injection. So next we come to trichotillomania. Now, trichotillomania is a disease which belongs to the group of psychocutaneous disorders. Means there is a psychiatric component to the cutaneous disease. Here the patient is pulling out their own hair. You can even see that in the name of the disease. Tricho means hair, tillo means pulling, mania is a psychiatric disorder. So here the patient has an urge to recurrent pulling out of their own hair. And in the psychiatric disorders, this belongs to the classification of obsessive compulsive disorders. Okay, so this is a type of OCD. Remember the classification? Trichotillomania is a type of OCD. Now, what is happening here? When the patient is pulling out their own hair, now this is going to lead to a patch of alopecia. So trichotillomania is a patchy alopecia. But when you look at the margins, what kind of a shape will it have? When the hair is being pulled out, will there be a particular round, oval, or a specific shape in which the patient can pull out the hair? No. You see here, it will be a bizarre shape of the patch. So most importantly, this will have a bizarre shape with an irregular margin. And when you look at the hair, you see the hair, you will see multiple broken hair of different lengths. Because when the hair is being pulled out, not all of them are going to break at the same level. Some will break closer to the scalp, some will be further, some will be pulled out of the root. So what you see here is broken hair of different lengths. And due to the trauma of the pulling, in some places you may see a perifollicular hemorrhage. This happens due to the trauma of the pulling of the hair. So a bizarre shaped lesion with irregular margins. It has broken hair of different lengths, perifollicular hemorrhages, and most commonly it is on the temporoparietal area. It is a quite nice clinical scenario of trichotillomania, and the patient may be suffering from a stress or an anxiety disorder. They may not admit to pulling out the hair, but your clinical suspicion, taking history from the guardian, all of these will take us towards a diagnosis of trichotillomania. Just remember the most common site, as you can see in the image here, is the temporoparietal area, because this is generally most accessible to the patient. Now, when you do the dermoscopy, also called as trichoscopy, there are some important features that you see. Most early in this image also, you can make out that there is a reduced hair density. So this is a patchy alopecia here. Some hair are broken. They're coming out of the same ostium and they're broken at this same level. This is called as the V sign. And other than that, you see some hair which have split ends which are irregularly coiled. This is called as trichotillomania. Okay, now when such an image of dermoscopy comes, the first thing that you see is the patchy hair loss. Second thing that you see is that the hair are broken at different levels. And if you are just able to make out this V sign, you know for sure that you are dealing with the dermoscopic image of trichotillomania. Then when the histopath is done, you see that there are evidence of hair follicle damage. There may be fractures in the hair shafts. There may be irregular distorted hair shafts, also called as trichomalacia. So whenever there is a damage to the hair shaft, it is called as trichomalacia. And around the hair shaft, you see hemorrhage, which is other. On the surface also, it is seen as perifollicular hemorrhage. So on histomath, trichomalacia and perifollicular hemorrhages may be seen. Treatment of choice, since it is a psychiatric disorder, treatment of choice is also belonging to that category. It is cognitive behavior therapy. So the treatment of choice for trichotillomania is CBT, that is cognitive behavior therapy. When you have to use medicines, medical management of choice is done with SSRIs. Okay, so treatment of choice is CBT, but drug of choice is SSRIs. So next we come to Tinea capitis, which is also a patchy, non-scarring alopecia. This is a dermatophytic infection of the hair shaft. So this is a dermatophytic infection of the hair shaft, and Tinea capitis of two types, non-inflammatory and inflammatory. When we talk about the non-scarring Tinea capitis, we are talking about the non-inflammatory type. Here we have grey patch and black dot type of Tinea capitis. Now, coming to the grey patch, here this is an ectothrix type of infection. Means the fungal spores are on the outside of the hair shaft, and this is generally caused by the Microsporum group of fungi. When you see the patient clinically, there will be a round to oval patch of non-scarring alopecia, which will be covered with a thick grey lusterless scaling. So here, the most important sign that you see is grey lusterless scaling on the surface, which gives it the name grey patch type of Tinea capitis. In the black dot variant, again you see a round to oval patch of non-scarring alopecia. Here you see multiple black dots on the surface. And in all Tinea capitis, there is always a partial alopecia because the hair are broken due to the fungus. So not all hair will be involved. There will be some broken hair, some intact hair. So it will be a partial alopecia. Just remember again, the involvement in black dot is an endothrix type of infection, which means the fungal spores are within the hair shaft. They will weaken the hair shaft, it will break at the surface, and it is this stump that you see as the black dot, generally caused by the Trichophyton group of fungi. So this one is called by the Trichophyton. And how will you see clinically? A patch of non-scarring alopecia with black dots on the surface, and there will be a partial alopecia. Now, you have to know how to differentiate black dot from alopecia areata. In alopecia areata, the skin is completely smooth and bald in the patch. However, in black dot and grey patch, you will see different signs like scaling or the black dots. Now we come to cicatricial alopecias. Cicatrix means scarring. So in this type of alopecia, there is a permanent, irreversible loss of hair. Now, in cicatricial alopecias, we can classify them as per the cause into primary or secondary cicatricial alopecia. In the primary, the disease is affecting the hair follicle primarily, leading to the hair loss. In the secondary causes, it may be a mix of systemic disorders or external factors or various other reasons that may have led to the scarring alopecia. Now, in the primary cicatricial alopecia, there is an inflammation. Depending upon the predominantly inflammatory cell here, we can classify it into lymphocytic type of cicatricial alopecia or a neutrophilic type of cicatricial alopecia. It just tells us what is the primary inflammatory cell in the skin. In the lymphocytic, we have lichen planopilaris, discoid lupus erythematosus, pseudopelade of Brock, frontal fibrosing alopecia, and alopecia mucinosa. In neutrophilic, there is folliculitis decalvans and tufted folliculitis, along with dissecting cellulitis of scalp. Amongst the secondary causes, there is morphia, traction alopecia, burns, Kirion favus, sarcoidosis, multiple others, but these are the ones that you should know. Now, starting with the primary lymphocytic alopecia, that is lichen planopilaris. Here, lichen planus of the hair. Pilaris means hair, so this is lichen planus of the hair. Here, the patient is going to present with violaceous or hyperpigmented patch of scarring alopecia. Look at the image here. There is purple color, may not be that really visible in the Indian skin. So what you see is hyperpigmented patch of scarring alopecia. How to identify scarring alopecia? There is scarring and wrinkling on the surface of the scalp, and you cannot observe hair follicle ostium, that is the opening of the hair follicle, that is blocked. So on this, you see a violaceous or a hyperpigmented patch of scarring alopecia. And this can be associated with LP of different areas, like there can be LP on the skin, there may be LP on the oral mucosa or the nails. So lichen planus elsewhere on the body increases the risk of having lichen planus pilaris. Then we have discoid lupus erythematosus. Here, the patient is going to present with patches of scarring alopecia. So on the areas that you have a lesion of DLE, there will be scarring alopecia. Look at this patch here, very beautifully. It has a white adherent scaling, and surrounding the patch there is a zone of hyperpigmentation, which is called as marginal hyperpigmentation. So in a lesion of DLE, you will see this white adherent scaling and marginal hyperpigmentation. When the scale is picked up, the white adherent scale is picked up with a forceps, there is a sign that we see. It is called as the carpet tack sign, also called as the tin tack sign. And DLE may be associated with photosensitivity, and in some patients it may progress to a full-fledged SLE. Okay, so here the most important thing that you have to remember is the sign, which is the carpet tack sign. Then we come to pseudopelade of Brock. This is actually idiopathic disease which does not have any known cause. Okay, so that is what idiopathic means. Here the patient will have small patches of scarring alopecia. So there will be small widespread patches of scarring alopecia over the scalp. And here there will be no scaling, no pustules, no pigmentary changes. In fact, there will be no signs of inflammation. The skin is completely smooth. See, it's completely smooth. And what is the sign when you see these small scattered patches all over the scalp? This gives the appearance of footprints in the snow. So the sign that you get here is footprints in the snow appearance. So please remember, the sign that you see in pseudopelade of Brock is the footprints in the snow appearance. And when a biopsy is taken from pseudopelade of Brock, the finding is a perifollicular concentric lamellar fibrosis. So what we see is a perifollicular concentric lamellar fibrosis. This is otherwise a non-inflammatory disease. You may not see a lot of inflammatory cells, but what is more visible is the concentric lamellar fibrosis around the hair. In folliculitis decalvans or tufted folliculitis, what is happening? There is a suppurative inflammation here. So there is a deep seated infection which is contributing to this disease. It is generally the involvement of Staph aureus, which is seen here. So this is a bacteria. Along with the disease process, there is also a deep seated Staph aureus infection in the hair follicles. Now, many times due to the exudates, the hair are joined to each other and they form tufts. Because of the appearance of these tufts, it appears as if they are all coming out of just one ostium. And where do you see this kind of a clinical picture? This is generally seen in the dolls that the children use, the Barbie doll, also called as the doll hair sign in tufted folliculitis. So this tufting here is called as the doll's hair sign in tufted folliculitis. Next, we have traction alopecia. Traction means pull. So this is a kind of alopecia which is happening due to a pull on the hair follicle. Now, what causes the pull? In this girl, as you can see, that the hair are being tightly worn in a ponytail. So a tight ponytail. Or in this girl that you see, a braiding has been done, which is again pulling the hair. So tight ponytails and braiding are two important risk factors for development of traction alopecia, and generally seen in the temporal sides or along the sides of the braiding, you see traction alopecia. Next, we come to morphea, which is actually a type of localized scleroderma. So scleroderma means fibrosis happening in the skin. Now, morphea can affect any side of the body. There it is going to cause a localized fibrosis. But sometimes when the morphea is affecting the forehead, in that case, the disease may progress to involve the skin on the scalp. And when the fibrosis affects the scalp, it is going to damage the hair follicles, leading to a scarring alopecia. So here what you get is a linear patch of fibrosis on the skin with a type of linear scarring alopecia on the scalp. This together is called as linear morphea. And when you look at the patient, it appears as if they have been hit with a sword. The scar is on the forehead extending to the scalp. This, as you see in the image here of Amir Khan also, the scar on the forehead extending to the scalp. Now, this gives it a clinical sign which is called as N. Coop D. Saber, where Coop means fight, Saber means sword. So, as if the patient has been hit with a sword. So, just remember, N-Coop D. Saber is another name for linear morphea, which can cause a type of scarring alopecia. Then we come to Tinea capitis. Now, Tinea capitis is a dermatophytic infection of the hair shaft. I have already told you that Tinea capitis, the non-inflammatory variants, can cause a non-scarring type of alopecia, but there are inflammatory variants also. These inflammatory variants cause a scarring, so they lead to scarring alopecia. This includes two types, Favus and Kerion. Now, Favus is a type of disease which is generally seen in Africa. In India, in some few areas of Kashmir, you may see Favus. This is caused only by one fungi, that is Trichophyton schondoni. Remember the name. This is an important question. Trichophyton schondoni. And when you see the patient, you see this patch where there is a scarring alopecia. And here the typical cup-shaped crusting is seen. So when you see this cup-shaped crusting, you know you are dealing with Favus. This has a special name. It is called as scutula. So the C-shaped crusting that you see in Favus is called as scutula. Then we have Kerion. Now, Kerion has excessive inflammation. When does the fungus cause excessive inflammation? When it is a zoophilic type of fungus. So this is commonly caused by the zoophilic fungi. Here the child is going to present with a red boggy swelling. So the patient will have a red boggy swelling which is studded with pustules. This is studded with pustules. There is easy pluckability of the hair, and there may be a regional lymphadenopathy in the form of occipital or cervical lymph node enlargement. So this is how a cheiron presents. Now, despite the red boggy swelling, despite the pustules, cheiron is classically only mildly painful. So that's a very important hint towards cheiron, that it is only mildly painful. These are the different types of scarring alopecias. With this, we finish our lecture on appendageal disorders part 1.